Hi, my name is Madhukar Pai. I'm the director of the McGill International TB Centre in Montreal, and this talk is on quality of tuberculosis care. I have no financial or industry conflicts of interest. Globally, TB continues to be the most important infectious killer of human beings. 1.6 million people died of TB every year, and that by itself is a sign that everything is not well in terms of quality of TB care. There is no reason why so many people should be dying of TB in 2020. 3.6 million people are considered missing. The gap between those that we are estimating to have TB and the number of people who are actually detected and notified, this also is a sign that something is wrong with quality of TB care. The other problem we know is a common issue, and one that worries me a lot, is the fact that despite the antiquity and the fact that TB has been killing humanity for decades, for centuries, we are still using very old tools. Tuberculin, BCG, microscopy, they all date back to Robert Koch and Röntgen, which is a century ago. Most TB programs have achieved 100% DOTS coverage or close to 100% DOTS coverage. But until recently, there has been very little information on quality of TB care that is offered. Coverage is not the same as quality, and this is a very important distinction that we need to know and understand. And this was reinforced beautifully this year by the Lancet Commission on High Quality Health Systems in the SDG era. This commission made a stunning claim that in 2016, 8.6 million deaths due to all diseases could have been averted by the health system, and 5 million of that was attributed to poor quality healthcare. In other words, poor quality healthcare is now considered a bigger killer than insufficient access to healthcare. And I think this is really important to keep in mind. Another recurring theme that we are learning now is that TB care was traditionally designed from the perspective of a health system, and it is primarily aimed at disease control. It's a public health driven vertical approach with disease control as the primary aim, which is why most TB programs are called tuberculosis control programs. Good care doesn't necessarily come as a centerpiece in TB care. TB control is given more priority than good quality care of people suffering with tuberculosis. And there are ways to mitigate and address this concern as well as retain the public health functions. And I will touch upon this later in my talk. I was part of a Lancet Commission on Tuberculosis, chaired by Ambassador Eric Gooseby, Dr. Samya Swaminathan, and Dean Jamieson. And this was published earlier this year in the Lancet, and it's available for free access. And this commission identified several problems, some of which I've already covered: high mortality, number of people who are missing, and so on and so forth. And in terms of priorities for solving the problem, the number one priority identified by the Lancet Commission is providing patient-centered quality care to all people seeking TB care. In other words, we must treat people with TB, with all forms of TB, at all ages, in all countries, with good quality TB care that is patient-centered. And that is the number one priority, and achieving that objective is really critical. Now, going back to the Lancet HQSS Commission, this commission defined a high-quality health system as one that optimizes health, but consistently delivering care that improves or maintains health, being valued and trusted by all people, and responding to changing population needs. And this equation is quite simplistic, but still, I think, an important and a powerful one. That good health is an outcome driven by two factors: utilization and quality. Utilization could be very high, that is, people are using health services, but quality might be suboptimal, and it could still result in poor health. So you need both. You need utilization and coverage. You also need quality. And this framework with the HQSS Commission put out is a very nice overview of what a high quality health system should look like. So you can see here at the bottom, there are these foundations that are important, and that includes governance, money, tools, healthcare workforce, number of doctors, and so on and so forth. And then there are processes of care that need to be good, competent. Care should be competent, correctly done according to guidelines and standards, and there should be a good experience for the healthcare user. And if all of this worked out well, there will be better health outcomes, there will be economic benefits, and people will have confidence in that health system. So for the Lancet Commission on TB, we essentially took this HQSS framework and then tried to fit all the data we know or we have about quality of TB care into this HQSS framework. And this infographic was published in the Lancet TB Commission, which provides a snapshot of how quality of TB care looks like globally. First is the foundations of TB care are quite weak. We have new tools, but it's currently not reaching enough people. We have healthcare workforce issues. We know that platforms, a lot of centers and health centers where there are no TB tests, for example, culture and DST is not widely available. TB care is not really decentralized. In most countries, TB care, adequate tools and systems are available only at the district level or higher. And this is really important. TB continues to be underfunded. Most national TB programs in low-income countries do not have adequate funding, and they rely heavily on donor funding. And these poor foundations also get reflected in the process of care. We know TB is diagnosed after an average delay of about 2 months. We know care cascades are poor. A good chunk of people with drug-sensitive and drug-resistant TB and latent TB will not get adequate care throughout the cascade of care. And all of this we know ends up with high rate of TB, large number of people who die, and nearly 500,000 people who develop MDR. And we know people also pay a lot of money to access quality TB care. So in short, using the HQSS framework for TB shows a pretty disappointing picture on what is really happening on the ground level in TB. And I will now try and provide more information on everything that I just showed in that infographic. And so the first thing I want to point out is this 13-country study supported by the Gates Foundation, which showed that TB patients have to navigate a long, complicated, tedious pathway to get their care. Many of them begin outside of the TB programs in the private and the informal sector. And when they do end up in the TB care system, they often seek care in places which do not have any diagnostic or treatment services. And all of this results in very poor outcomes. Next thing we know is TB takes about 2 months for TB to be diagnosed in most high burden countries, and multiple providers need to be seen before TB is detected. And these are 3 studies from different parts of India, which show a stunning picture of how many times somebody with TB needs to bounce around again and again and see multiple providers before they're finally diagnosed and treated. And this is not unique to TB to India. It has been noticed in many other countries as well. In short, multiple providers being seen and a long time being taken is the norm rather than the exception in terms of TB diagnosis. Now, what about looking at cascades of care? If you look at cascades of care, and this is a nice publication by Subbaraman and colleagues in PLOS Medicine this year, which provides like a manual or a workbook on how to construct cascades of care for TB. And the graphic here illustrates all of the areas where we know the cascade of care should really focus on. And you can see what these are. Number of people who did not access a TB test, proportion that did not get diagnosed, proportion not registered in treatment, did not achieve treatment success, and ended up with poor outcomes. So let's look at what we know about cascades of care for TB. This is a nice publication in Journal of Global Health earlier this year from 30 high burden countries. This is like based on routine data from WHO reports and country reports. And you can see in the 30 high burden countries, only about 50%, 49% successfully go from start to treatment completion. That's why I have this icon here which shows 1 in 2. 1 in 2 people with active pulmonary TB in high burden countries are successfully able to get through the entire cascades of care. If you look at drug-resistant TB, this is a publication in International Journal of TB and Lung Disease by Emily Kendall and colleagues. Again, a global cascade of care for MDR TB. You can see of the about half a million people estimated to have MDR or RIF-resistant TB, only about 15% successfully navigate the cascade of care. So that's less than 1 in 5, which is what I'm showing in the icon on the right side. Less than 1 in 5 people with drug-resistant TB are successfully navigating the cascade of care. What about country data? If you look at TB cascade of care in India's public health system, again a publication by Subbaraman and colleagues in PLOS Medicine, you can see for active TB, it's about 39% that successfully go through the cascade of care in India's public sector, and it's only 1 in 10 people that successfully navigate the MDR TB cascade in India's public system. Very disappointing results, despite the fact that India, for example, has achieved 100% DOTS coverage. So this is the dissonance between coverage and quality. If quality is high, the care cascade should not look this bad. South Africa is no different. This is data from Pren Naidu and others published on the South African public system. You can see for active TB, only about 50%, 1 in 2 people, successfully navigate the care cascade in South Africa. For drug-resistant TB, it's only 1 in 5 people who successfully navigate the cascade of care in the South African public system. What about children? These are data from Uganda and Kenya among children in 32 rural communities. Again, you can see only about 20% of children, 1 in 5, successfully complete the cascade of care for pediatric TB. Latent TB, this is work by Hannah Alsdorf, Dick Menzies and colleagues here at McGill. Again, very poor cascade of care. Only about 19% of 1 in 5 people successfully go through the cascade of care for latent TB infection. These are global data based on a systematic review and a meta-analysis. So I want to again reiterate that if you look at cascades of care and the continuum of care as a strong indicator of quality of care, regardless of where the analysis is being done, which age group is being looked at, which form of tuberculosis is being looked at, these results look terrible. Cascades of care are leaky in TB. Too many people are dropping through the cracks. Now, there is another way to look at this, and that is to look at whether people with TB are getting competent care. And here is work from our consortium with Jishnu Das at the World Bank and a large number of people involved. And our group website is listed here. And we essentially pioneered the use of simulated or standardized patients to assess quality of TB care. And standardized patients are also known as mystery patients. These are people who are trained to act as TB patients and given documentation and so on and so forth to consistently show the same signs and symptoms and history in various settings to see what exactly is done to them when they present to the clinic in multiple countries. And this methodology, which we first began with India, has now successfully been used in 5 countries around the world and has produced very rich results. And this website carries all the information, including a detailed manual on how to conduct these simulated patient studies. So here is a snapshot of all the major publications that we and others have published using this methodology of simulated patient data. And the data shown here are from 4 countries: India, China, Kenya, and South Africa. And I'm going to try and summarize just a small slice of these studies in the coming few minutes. We use many different types of presentations in these simulated patient studies. And the one that I'm showing you here is the most important. And this is the classic case of suspected TB or presumed TB. This individual will walk into a clinic and say, I have a long-standing cough that is not going away. And if the healthcare worker were to probe and ask more questions, then the answers will be very indicative of suspected TB. How long is the duration of the cough? 2 to 3 weeks. Is there fever? Yes. The history of weight loss? Yes. Is there loss of appetite? Yes. In other words, this is a very, very straightforward case of suspected TB. And at a minimum, we expect these individuals presenting with suspected TB either to be referred to another place where TB testing can happen, could be the DOTS program, could be another qualified doctor, or any test for TB was considered acceptable. Chest X-ray was acceptable, sputum smears was acceptable, gene expert was acceptable, cultures were acceptable. All of these were considered acceptable tests. So referral was a good idea, and any type of a TB test was considered a correct management or a good outcome for this case. And here are the results from these 4 countries that I just mentioned. And you can see here the column which says correct management. That's the definition that I just gave you, which is either a referral or any TB test. It's a composite variable. And you can see in Delhi, only 1 in 5 of these simulated patients were correctly managed. In Mumbai and Patna, it's about a third were correctly managed. Nairobi, in the private sector, only about a third were correctly managed. Public sector did much better. Rural China, in the village and township clinics, only about a third were correctly managed. Correct management went up dramatically once the simulated patient reached a county hospital. In the South African public sector, about 40% were asked to get a TB and an HIV test. And in the public sector, about 80% were recommended to get a sputum TB test. So again, public did better than private, as in the case of Kenya. And in the South African private sector, in KZN province, only about a third were correctly managed. Another striking finding is that referral is very uncommon at this primary healthcare level. Primary care providers generally do not refer a suspected TB patient. They prefer to keep the patients themselves. And so if they're not testing for TB or referring, what exactly are these primary care providers doing? Well, the answer is medicines, medicines, more medicines. On average, they give about 3 to 4 different medicines, invariably an antibiotic, a cough syrup, sometimes a steroid, and other non-specific therapies like anti-inflammatory medicines and bronchodilators. In other words, the striking finding at the primary care level for somebody with suspected TB is under-testing and over-medication. Polypharmacy is the way most primary care providers manage with suspected TB. And this is why it shouldn't shock us that TB is never diagnosed early. It takes multiple visits before TB can be picked up. And a failed antibiotic, multiple rounds of failed antibiotics, is the way most primary care providers deal with people with suspected TB. So competent care for TB, suspected TB, is simply not happening at the level that we are looking for across countries. Empirical treatment, as I mentioned, polypharmacy, is the norm rather than the exception. So we've done ethnographic work in India primarily, as well as in other countries like South Africa, and we see that empirical management is extremely dominant. And turns out that it's not just for TB. This is the way primary care deals with a variety of different conditions, whether it's angina or asthma or pneumonia. All these conditions, simulated patient studies have shown that there is very little testing and there's lots of empirical over-treatment with antibiotics and other medicines. So how can we address these major issues? I have 4 suggestions here. One is we have to upgrade our toolbox in TB. We cannot use century-old tools and hope to offer quality care to patients. We must use human-centered design to make TB care more people-centric. As I mentioned earlier, the current TB care model is delivering what the National TB Program or the government wants. It may not quite resonate with what people with TB are telling us that they want. We must improve quality of care in both private and public sectors. Yes, public sector is better than private, but you also saw from the cascades of care, public sector has got a long way to go to improve the quality of services. And then we need to address the foundational issues that we already hinted earlier. It's not just a TB problem. If the health system itself is very weak, then I doubt that TB care alone can be spectacular in an otherwise underwhelming health system. So here are these suggestions fleshed out in greater detail. So this is a op-ed that I wrote recently on why we need to science the shit out of TB. A tongue-in-cheek way of saying that we absolutely must use science to develop much better tools than what we are using today. And in this Lancet seminar on TB published this year, led by Jen Furen and Helen Cox, we had our dream TB clinic charted here, and you can see there's a lot we can do today for someone with presumed TB or suspected TB. Could we use apps and social media to nudge them to seek care earlier? Could we develop or use rapid triage test, whether it's biomarker based or a digital X-ray with a CAD software? Could we do point of care molecular testing, such as the Gene Expert Omni or MolBio, and get a rapid RIF resistance result quickly? Could we then confirm DST using sequencing? Could we put or place our TB patients on much shorter regimens? The recent FDA approval of Pretominid and the BPAL regimen, the 6-month oral regimen for XDR TB is a great step in the right direction. We must shorten TB therapy to make it more easier for patients to complete it. Could we use digital adherence tools to get people and encourage them to complete therapy? And there are many different ways now to give patient direct benefits and cashless payments and social benefits. And then, of course, the news about a new vaccine for TB with promising results from GSK is all indicator that hopefully in the future we will also have a new vaccine. And we are working on similar care models now for latent TB, childhood TB, and TB HIV. But there is no doubt that the future lies in bringing all these technologies together into an ICT-connected, electronic, cloud-based platform where all the data are available to healthcare providers and the TB programs on a dashboard. Now, the next issue is, in addition to upgrading tools, we have to really ask, even if the tools are good, if it does not connect with people and their lives, will we ever succeed in improving quality of care? So is TB care human-centered? And I would argue that methods like directly observed therapy, which have a role even today, are not quite connecting with people. DOT expects people to come to the clinic or swallow the pills in front of another healthcare worker, while in 2020, I really don't see a need for such a command and control type of a methodology for helping people complete a treatment. There are much easier ways to help nudge people and help support people, and DOT should not be the only tool that we use. For example, there are now smart pill boxes that can be used, where you open the pill box, a signal is sent, and anyone can track whether the pill box was left unopened for many days or not, for example. I am currently using a smart pill box for my pre-diabetes medicines, and every morning I get a text message reminding me to take my metformin tablets. So we can use simple text messages to nudge people. In India and other countries, they're using call centers where people are, human beings are calling people with TB to help them get their treatment and their adherence. It's possible now to do video DOT, which is much simpler than people taking half a day off to come to the health center. And there are other cell phone based tools like 99 dots. And more importantly, there is also the possibility of pairing TB survivors to help new TB patients through phone and WhatsApp and getting them to complete treatment. So in short, it's a very, very rich landscape of tools that we could use. And some of them are much more human-centered than older methods like DOT. So when we talk to patients who have survived TB, they tell us these are the sorts of things that they care a lot about. For example, they want to be communicated with WhatsApp and Facebook and social media because that's what they are currently using in their daily lives. They want care close to home. That's a big deal for them. If they have to travel across the town to get TB treatment, they're probably not going to be able to do it. They are asking for extensive counseling before testing for TB, pre and post-test counseling, kind of like what HIV does. TB patients are asking for much shorter, non-toxic regimens that are based on drug susceptibility testing. They are asking for individualized support. They don't want a single plan like DOT because it does not work for all. They want peer support from other TB survivors and mental health support. And they also want to know what is their life going to look like after they complete TB treatment. What is the plan to rehabilitate them and get them back into the workforce and so on and so forth. So if we use human-centered design, we'll have to come up with a vastly better system than what most TB programs are able to offer today. And I also am convinced that TB programs must not just talk about coverage. Coverage data are important, undeniably, but it is simply not adequate. We must measure quality of care and track these measures over a period of time. Bruce Agins, Eric Gooseby, and Aditya Katamanchi, Mike Reed, and others at UCSF along with us recently published this paper in Lancet Infectious Diseases on going from what is wrong with quality of TB care to actually how to improve quality of TB care. So this is one of the few papers that explicitly focus on how to do QI for TB. And this paper has this nice infographic which tells us that it's not just something that is done at the facility level. Facility level is important. We must improve quality of care at the health facility level, but there also needs to be strong leadership from the ministry, a greater attention to quality of care from national TB program managers, and that needs to percolate down to the subnational level, regional, provincial, or district level, and then finally the actual work gets done at the facility level. Just focusing on facilities, it definitely is not adequate to do good QI. And so thankfully, and it's very inspiring to see some countries starting to do TB QI. I had the opportunity to visit South Africa a year ago, and I saw their QI program in action, where at the health facility level, they're actively trying to ask, why is it that we're not able to screen people with suspected TB? Why is it that we're not able to put diagnosed people on treatment quickly? And they're doing these plan, do, study, act cycles, PDSA cycles, to cycle through and identify solutions to their problems. Quality improvement has also been successfully done in the private health sector in India. This is the private provider interface agency projects by PATH, World Health Partners, along with Mumbai Corporation and the Government of India, which successfully dramatically increased private sector notification in Mumbai and Patna, which resulted in large numbers of people tested for TB and put on TB treatment, and also completing TB treatment in the private sector. And private sector is not easy to work with, but even in the private sector, if we do it correctly, we can improve quality of TB care. So all TB programs need a quality dashboard. This is from the Lancet HQSS Commission. It's a very nice illustration of how a dashboard should look like. This is not for TB, but this is a generic type of a dashboard. But something like this, customized for TB, is something that every national TB program must be putting out on a regular basis. And we should hold them accountable for not emphasizing quality, and TB survivors must hold them accountable for lapses in quality of care. And all TB programs absolutely must listen to patients. Very few TB programs do client patient experience or user satisfaction studies. And the literature is all over the place. There is no standardized tool that all countries use. And we must ask if TB care was respectful, were TB patients treated with dignity, were they given adequate time to ask their questions, were they treated with confidentiality, and what sorts of support systems are they asking for. So we must start listening to TB patients much more than we are doing today. And that's why the public health oriented approach does not quite resonate with what TB survivors are telling us. And all TB programs must analyze cascades of care. And this manual in PLOS Medicine is a great start point. And they must look at their data and put out data on an annual basis on what their biggest gaps are and what they've done to address the big gaps that they found using QI programs. And lastly, we need to expand the solution space for improvement. In other words, facility level QI is important, but we also should improve the health system as a whole. If the entire health system is underfunded or the TB program is underfunded, I just don't see how facility level QI alone is going to do the trick. And this is why I now feel, and I'm convinced, that every one of us working in the TB space must think beyond TB. Because TB alone, even if we fix somehow quality of TB care alone, but TB patients have diabetes which is untreated, or TB patients have pregnancy that is not adequately managed, TB patients have other lung diseases like COPD that they need help for, they have HIV that they need ARVs for. We simply cannot afford to just tweak TB alone and hope that everything else is going to work out okay. Which is why the global push from WHO and all partners on universal health coverage is so important for us. Every one of us working in TB absolutely must find a way to advocate for UHC. And the Lancet HQSS Commission provides us 4 universal actions. One is govern for quality, redesign service delivery, transform the health workforce, and ignite demand for quality. And I want to finish by sharing some interesting reading materials for all of you. I'm an associate editor of the Journal of Clinical Tuberculosis with Dr. Temesgen from Mayo Clinic as the editor-in-chief. We launched an entire series on quality of TB care in the Journal of Clinical TB, and more than 10 papers have already been published in our series. So I welcome you all to go to this website and access the entire series on quality of care as a way to continue your reading on this important topic. And my last comment to everyone is to say that we have learned a lot over the last several years, that simply focusing on TB coverage is just not adequate. Quality of care must be a center focus, and the quality of care that we delivered must be human-centered for it to really be taken up by TB patients and for them to see it as something that they care and value a lot about. Thank you very much, and I would be happy to take any questions via email.